we can start actually. This is our fourth webinar of on the topic of update of spine surgery, and this time we have very distinguished speakers to talk and discuss about the surgical options for cervical disc herniations. I give the moderator, Dr. Oscar Luis Alves, and to start to moderate the session. Dear Oscar.
Thank you, Mehmet. Good afternoon, everybody, and welcome the outstanding faculty and also the participants. And over the next hour, as Mehmet said, we'll debate on the surgical options for cervical disc herniation. I would like to have very active conversation and participation, so I invite all the participants to write their questions on the chat. They will be given to the speakers. And this is a joint venture of International Academy of Spine, Middle East Spine Society, and the WFNS Spine Committee. And without any further delay, we'll hear Jutty Parthiban, professor from Coimbatore, India, very well-known person on the spine world. And he will talk us about fusion. Please, Jutty, go ahead.
Thank you very much, friends, and thank you for this great invitation. And I'd like to share my screen here now. Are you able to see that?
Yes, just screen mode, please.
Able to see?
Yes, but put it on screen mode.
Right?
Yeah, perfect.
Yeah, thank you very much. And this is a kind of maybe something a newer one for anterior cervical discectomy and fusion. But I like to give this talk in Korea this time last week. But I like to say something about we all know that this symposium is totally focusing on spine fusions. We all know that ACDF is an excellent surgical procedure. Generally, the fusion rate is very good in ACDF. Though the techniques differ, the goal is the same. The achieving the goal with most best result is the final aim of all the neurosurgeons. The aim is to have at least morbidity, and the things should be affordable, and the available cages and graft materials. And finally, it should be surgeon friendly. Now, when we look into this particular slide, I always consider this photograph has properties like, osteogenic, all 3+. And this is the cancerous bone, and none other like. And if you have a vascularized bone, again you have few plus and few 3+, but nothing like what we have in the cancerous, except it does not have a structural support. Bone marrow aspirate again like this. You can see that whatever said and done, the cancerous bone is the best bone, except the disadvantage is that the donor side morbidity and increase over time in the blood loss because of the donor side approach. But when you see the synthetic materials also, whatever material available in the world, if you look at all these things, and nothing matches the cancerous bone. Nothing matches the cancerous bone. Of course, the tricalcium phosphate, it has more structural support and has got osteoconduction. So this is the one thing which is more commonly available. Then the BMPs are very expensive. Now we all know that this tricortical bone graft is, this is what the piece of tricortical bone graft we get from the iliac crest and harvest it from a faraway place and then place it in between these two vertebral bodies snugly so that a good fusion occurs. And this is the structure where we all believe in that. Way back in 1991, we did one research in this particular fusion technique, like the keystone fusion technique like this. And we started understanding what's happening to the fusion rate and also the settlement. And we published this way back in 2002. This is the autograft from iliac crest. You can see here, C5, C6, C7, and this is after a fusion. If you see carefully that the fusion has happened very well, of course, there is not much of settlement of the graft in this case. So this one we published in 2002, but the same article was later on was mentioned in Jeffrey Wang's meta-analysis. It's a systematic review where they analyze our paper also, in which they find that 93% of fusion in ACDF with autograft, while we had an allograft with ethylene oxide treated allografts had only 90% and crumbling down. And there are many other studies. All other studies showed that ACDF is best performed with a good autograft. Now, subsequently, we had these grafts. You have the cages, the titanium cages, and then the P cages were used. But still, whatever you do that you may have to fill up a graft, an autologous graft or a synthetic graft here to augment the fusion in these cases. So standalone 3-level cages fusion can be done. So this is how the cancerous bone have to be filled in the cages and then it should be placed. Otherwise, we can also take these cortical osteophytes can be taken up, and you can also take some bones from the cartilage and use it for the fusion. So ultimately, we want a good fusion. To improve the fusions, many other techniques have come with the peak and also the screws directed into the vertebral bodies that makes better stability as well as a good fusion. Now, looking back with our experience, if you see carefully, this is a case of a corpectomy. These are the discectomy done here and corpectomy. If you look at this, we have a very rich cancerous bone here. This cancerous bone is unimaginably rich. They are fresh. They are very close to our anterior cervical discectomy sites. So this was not well, researched by many people. Now, later on, I found that this particular cancerous bone must be used to fusion in the cages. That is to evacuate, that means to remove these cancerous bones from the adjacent vertebral body and replace it into the cages at the intervertebral disc space. So this was my concept, which we developed long years ago. And later on, and this is the diagram and a schematic diagram, you can see the cancerous bone is taken out and then placed here. This is for a good achievement for the fusion. So you can see here, this is cancerous bone is taken and then packed there. Now, this technique we call as adjacent vertebral body corticocancerous grafting, ABG or ACBG. The technique is like this: after putting the cage from where you have put the pins for distraction, you can do cortisectomy there, a small cortisectomy, curate the cortical bones, and place it immediately inside the cages and pack it well inside and pack it well nicely. You can take as much as possible in these cases from adjacent cages, adjacent vertebral body. Now, this is the technique. More corticocancerous bones are harvested from the lower vertebral body and packed inside the cages. So if you have a good cancerous bones, then you can do this technique very well. This is the technique. And if you want to add some of the cortical bones on the osteophytes, you can also mix that with that. So finally, if you see, this is the construct. The construct becomes very good, and one can find a very good fusion. Now, when we did this, we also had some doubt what will happen to this excavated cancerous region that can it promote a vertebral body collapse and hence lead to loss of lordosis? This was a question which came in the mind. Or should we pack the excavated region with the bone with the substitutes? So what are the contraindication for this technique of ACBG and how many levels we can do? These were some of the questions we asked ourselves. Now I'll show you some cases. We all this done many, many years ago, 2016. And you can see this is the place from where the bone was removed, and there's a beautiful fusion. The fusion has occurred very well in this case. Now you can see from June 2016, June 2017, 1 year duration, and 2018, 2 years duration. We found there's a good fusion occurring everywhere, beautifully between the cages. At the same time, the lordosis was also well maintained. There's a good fusion with the lordosis well maintained. This is another case where you can see the place from where the bone is removed and then placed inside the cages. And the same case, we can see that how it has fused in 2000 March and 2018. You can see beautifully the fusion is extremely good, satisfactory, and you can see the lordosis is maintaining. There is no collapse, there is no lordosis. Now this is another case. You can see from where it is being taken here. And the same case you can see here, 2 months, the corpse angle good. There's a mild settling. You can see there's a mild settling. We also measure the mild settling. But 7 months, you can find that everything is looking good, except this case, we found the lordosis is slightly compromised, but in looking patient has no symptoms. These are only radiological finding. And this is in 2015, January, operated. And you can see over a period of 1 year time, and there's a good fusion. There's no problem in flexion, no problem in extension. There is a beautiful fusion has occurred with this technique. Only one patient, we attempted in doing an osteoporotic case, and we didn't like it because I could able to see that this space was, the vertebral body was collapsing. Though there was a fusion, I found this a good fusion in 2 years period time, but there was mild subsidence, but the corpse angle was the same. So I particularly realized that it is not very good to use it in osteoporosis, though there is a good fusion has occurred in this case. So fusion is very good with this cancerous bone, which is taken from even in osteoporotic bone. So at that point, this was published, this was presented with the first 28 cases. Now we have done large number of cases. This one was presented in 2016 and later on in 2018 in Istanbul also. There was no significant vertebral collapse. A few millimeter of settlement of the vertebral body was seen, but which was insignificant. There's not much of significant change in the lordosis. There's no clinical significance here. It's only a radiological observation. The fusions were all very good in all cases so far. There are some limitations. It's not good in osteoporotic bones. And it is not feasible when the vertebral body height is not significant. That means if the vertebral body height is very small, then it is very difficult to take much of cancerous bone. The cancerous bone stock will be very less. So it is not indicated in kyphotic segments. And multi-level may not be possible, maybe not more than 2 levels. Up to 2 levels, one can do, not more than that. We have done more than 2 levels, only 2 levels up to that, not more than that. Now, subsequently, what we did, we also tried to pack the empty space, excavated space with the TCPs. And this showed us a better result. We were very happy. You can see the TCP very nicely taking up, and the fusion was very fast. And this TCP is packed in this place. In subsequent cases, we started doing this. Minimal TCP was packed. Here you can see the TCP is packed here. The corpse angle is good. And this is another case in 2017. You can see the TCP packed here. The fusion is good. And there's not much change in the corpse angle for single level. This is another case you can see here. This is where the TCP is packed and the fusion is good. Very satisfactory. So many cases we have done. Now we have done more than 100 levels now in the past 8 years. We published this in our Journal of Spinal Surgery in India. First, we published this as a technical note, and then we did a lot of analysis, and we realized that this technique is very worth doing it. This will be helpful in two ways. One is that we don't need to go for an autograft for a cancerous bone. Good cancerous bone is available just to your next door. It is your next door neighbor. You can take the cancerous bone, and the small area where evacuated can be filled with the TCP. So the adjacent vertebral body is the nearest gold mine for cancerous bone, and we need not go anywhere far. While cages or scaffolds, cancerous bones are osteogenic and the best available. Our observation and studies suggest no clinical and radiological adversity on this technique. We presented this in these following congress, like in APCS in 2016, WFNS in Istanbul in 2017. Again, I did the same thing in China in 2018, and this time in Korea. So I find that this is very good. When we were looking at the literature, we found two beautiful articles. That means these articles were all published at the time when I was doing clinical surgery. One is by Pitson et al. What they did was they placed one graft and then removed this cored out these bones and then did the compression study. Their conclusion was there does not appear to be a significant early biomechanical weakening of adjacent vertebral body caused by aforementioned technique of local bone harvest. This was the big concern, but this paper is an eye-opener. This paper, I read it very late. It came to me, my eyes very late, and subsequently I came through another paper in 2017 when I was presenting all over the world. I found that this paper is by Watershield. Similarly, they have removed cancerous bones like these plaques at 2-3 levels, but they used an implant and then tested the compression test, and nothing happened to this region. So their conclusion is the local autograft harvested from adjacent vertebral body reduces the morbidity associated with the second surgical site, while minimally reducing the compressive strength of the donor vertebra in osteopenic model. So in osteopenia and osteoporosis, one can avoid this technique, but however, you can always use in very normal patients. So these two articles are very good. Along with our article, it shows that adjacent vertebral body graft is very acceptable one. We also understood to have so many techniques are being done without being an implant, like anterior cervical discectomy without effusion, oblique corpectomies, and then functional anterior discectomies. And you also have vertebral body fenestration discectomies and anterior way corpectomy. All these techniques were done with good fusion rates. So one has to rethink about using a lot of metals over there. The newer concepts are always thought-provoking. Sometimes it is called thought-provoking, is called controversial until realized. And many accepted concepts have vanished too. So this is my conclusion slide. Thank you very much for your kind hearing. Thank you. Thank you.
Thank you, Jutty, for bringing us this very elegant technique. I'm not afraid of compromising the ALL, anterior ligament, which gives stability to adjacent segments. Have you seen increased number of adjacent segment disease with this technique?
Sorry?
You're removing ALL, okay, right? When you do this technique.
I'm removing
and
only
ALL is important for stability, for the lower and upper level.
Okay, you're talking about adjacent segment.
Yes, related with violating the anterior longitudinal ligament.
Okay. See, whatever observation I had in these cases, whatever observation, there's not much of significant problem in the adjacent segments. I would certainly like to relook into this because I've been following all the cases very regularly. So as of now, I have not seeing very severe problems in this technique because my selection is very clear. I stopped doing in the first case, only one case I did with osteoporosis. I stopped it because there was subsidence. I stopped with that. And then after going through many cases, then I saw this Watershield's second paper. It gives very nice idea. This is a excavating, that is you're removing little bit cancerous bone, does not happen anything problem. But in osteopenic patients, it may cause mild settlement. There's not much mentioned about the one level above adjacent segment. I will certainly look into my cases which are there. Now I have done more than 100 levels of this technique. We'll certainly look at it. It needs a separate study altogether.
Okay, very quick answer here for a question of Dr. Shihab Eldian. What is the amount of cancellous bone that you are able to get?
What?
What is the amount of cancellous bone that you are able to obtain, to get? Very quick answer.
Oh, how much you can take it?
Yeah.
Okay, right. Okay, this is a very good question because whenever I see, I myself see each case looks different. When we start scoping out the cancerous bone, some are very fragile, some are very, very hard. So what I do is that when it is fragile, actually I take less. But when it is hard, I take more. So my technique is to taking this cancerous bone from away from the fusion site.
Very
For
good.
example,
Okay.
away from the fusion site, yes.
Okay. Thank you so much, Jutty. Very, very interesting technique. So now I from anterior foramen